Hello, my name is Owuraku Titi-Lartey, and today I'll be going through a bit of neurology. In particular, the topics I'll be going through are migraines and other headaches, dizziness and vertigo, dementia, and then ending with Parkinson's and neurodegenerative disorders. So starting off with migraine and headaches. Headaches are classified according to primary and secondary. Primary headaches being migraines, tension headaches, and trigeminal autonomic cephalgias, which is cluster headaches and other associated conditions. Whereas secondary headaches includes headaches which occur due to things such as vascular diseases such as subarachnoid hemorrhage, or cerebrovascular malformations, or meningitis, or head trauma, and trigeminal neuralgia, so things along that line. So it's important to understand what a headache actually is, and what the origin of pain in a headache is. So essentially, you have a pain which originates from between the orbits and the occipital, so the eyes to the back of the head, and it arises from pain-sensitive structures in this area. So the brain parenchyma itself, the actual brain, has no sort of ability to sense pain. It's the structures around it, such as the vascular structures, the dura mater, the cutaneous subcutaneous tissue on the scalp, skeletal muscle on the scalp as well, the periosteum around the bone, the ears, the eyes, teeth, sinuses, and nasal cavities. And as such, diseases arising in these structures can lead to a headache. So it's important to have a broad mind when you're thinking about what the cause of a person's headache is, because it can be due to a disease affecting any one of these structures. So, for example, a person with otitis media, or acute angle closure glaucoma, or a toothache, or say a dental abscess or a sinus infection, may present with headaches which may be referred to other parts of the head. And usually structures which are above, supratentorial structures are referred to the anterior 2/3 of the head, whereas infratentorial structures refer to the back. So this just goes into a bit more detail with regards to what I said. So this diagram shows that structures in the supratentorial region are referred to the anterior 2/3, whereas if they're infratentorial, they're referred to the posterior third of the skull. And again, this diagram helps to further reiterate that the brain parenchyma itself doesn't actually sense pain. However, pain comes from the structures around the brain, and depending on where these structures are, they refer to different parts of the skull itself. So moving on to migraines. Migraines are actually relatively common. The most common cause of episodic headaches, not the most common cause of headaches themselves, but the most common cause of a person having repeated episodes of headaches. They're more common in women, a ratio of about 3:1, and they tend to peak in about the 20s to 30s. However, it is also possible for people to have migraines at later ages, but it's important to consider other potential causes of headaches in the elderly, such as, say, malignancies. There tends to be a strong family history with headaches. The majority of headaches are thought to be inherited polygenetically, so the majority of migraines, and so the majority of migraines occur because of the inheritance of a wide range of genes. However, in some people who have familial migraine, it tends to be associated with a mutation in something called the SCN1A, which is the alpha-1 subunit of PQ type voltage-gated calcium channels. It's also a nice thing to know is that the word migraine is derived from the Latin word for hemicrania, meaning half skull. With regards to the pathophysiology of migraines, it's thought that the aura associated with migraines is triggered by something known as spreading cortical depression. So essentially, you have neuronal depolarization starting off from the occipital cortex, which is why you tend to have visual errors and visual signs before the migraine. And this spreads from posteriorly and anteriorly quite slowly, which is why the ura tends to occur sometime before the actual migraine. And then this leads to the activation of something called the trigeminal vascular system. So this spreading cortical depression causes activation of the sensory neurons, which innervate the large cerebral vessels and the dura mater surrounding the brain. So it's, as I've mentioned before, it's the structures around the brain which cause the headache, not the actual brain itself. And so the stimulation of these structures and the trigeminal ganglion leads to the release of vasoactive peptides such as substance P, neurokinin A, and calcitonin gene-related peptide. And so with regards to the classification of migraines, you can classify them into migraine with aura or migraine without aura, and then migraines can then be further classified into migraine with a typical aura, migraines with a brainstem aura, hemiplegic migraine, and retinal migraines. With regards to what a migraine with aura is actually classified as, it's seen as a recurrent attacks which last several minutes. They're typically unilateral and fully associated with fully reversible visual, sensory, or other central nervous systems, which is then followed by a headache. A person with chronic migraine would be classified as having a chronic migraine if they have migraines on 15 or more days per month for at least 3 months. And there are also complications of migraines, such as status migrainosus. So this is essentially a migraine which lasts more than 72 hours. Persistent aura without infarction is when a person has an aura for 1 week without signs of infarction on imaging. A migrainous infarction is when a person has aura symptoms associated with an actual ischemic brain lesion. And then a migraine aura-triggered seizure is a seizure which occurs following a migrainous aura. And so with regards to the subdivisions of migraine with aura, a person with a migraine with a typical aura is an aura which consists of visual and or sensory and or speech language symptoms with no motor symptoms or motor weakness, and is characterized by a gradual development of each symptom for no longer than an hour. Whereas a migraine with a brainstem aura is an aura which originates on the brainstem, such as a vestibular migraine, and tends to be associated with symptoms of brainstem abnormalities, so vertigo, feeling dizzy, ophthalmoplegia, and things along that line. Hemiplegic migraine is when the aura is characterized by, say, unilateral weakness. So the person may have symptoms which appears to be very similar to a stroke, so one side of the body is weaker than the other, which then dissipates, followed by a migraine, so the symptoms of a migraine attack. Whereas a retinal migraine is when a person has repeated attacks of monocular visual disturbance, which can be scintillations, oscillating scotomas, or blindness, which is associated with a migraine headache. So migraines tend to have multiple stages. We've already talked about the aura, but there tends to be also something which is known as the prodrome. The prodrome is one of the stages of a migraine in which a person has very abnormal, strange sensations. So things like feeling very hungry, yawning a lot, pain in the neck. They feel very on edge. They feel as if they're retaining a lot of fluid, a bit bloated or very swollen. And they may also complain that they feel as if something is wrong. So during this period of time, they don't experience the flashing lights, which is typically associated with auras and the other type of auras that I've described. And this tends to occur for about 24 to 48 hours before the actual onset of the headache. The aura, as I've already described, tends to be seen in about 30% of patients. The sort of characteristic exam question, aura, is a scintillating scotoma. where the patient may complain of flashing lights or difficulties in seeing things in the periphery of their vision. And they may also have a degree of photophobia, feel as if very bright lights are very uncomfortable. And then the headache characteristically lasts for about 4 to 72 hours if there is no treatment. And then there's also the resolution and the recovery, which tends to vary in how long it takes. Migraines tend to be triggered by certain things, or can be triggered by certain things. There's a very wide range of things which can trigger migraines in people. There's a mnemonic that I use to remember some of them. So things like chocolate, hangovers, orgasms, cheese, oral contraceptive, lying, so sleeping in, alcohol, travel, and exercise can trigger migraines in some people. So when taking a history with regards to headaches, it's important to ask people, was there anything which triggered it? Have you noticed anything that tends to happen before you have the headache? It's very important to determine the chronology of a headache. Now on to the actual symptoms. Now into more detail with regards to the symptoms of the aura, and with a few images helping to describe helping to show the sort of things people may see when they have auras. So, as I've mentioned, the aura may be visual, sensory, or motor. If it's a scintillating scotoma, this is one of the visual symptoms. A person with a bacillar or brainstem aura may describe unsteadiness on their feet, dysarthria, so difficulty pronouncing words, vertigo or limb paresthesia, unilateral paralysis and hemiplegic auras, unilateral visual loss, which is reversible, which would occur in a retinal migraine, and this tends to evolve over 5 to 20 minutes. So this image is just showing how the aura may evolve over time. So it starts off with a sort of isolated paracentral scintillating scotoma, which over time spreads and it starts to occupy more of the patient's visual field. Other things which may be noticed are wavy lines or metamorphosia. So the symptoms of the actual migraine headache, they characteristically last 4 hours to 72 hours or 3 days. And in order to determine, or in order to say that a person is likely to have a migraine, they need to have at least 2 of unilateral pain. So migraines tend to affect one side of the head, unilateral, which is of a throbbing type pain, so not a band type or piercing pain, is throbbing. It tends to be of quite moderate to severe intensity, and the patient may also have motion sensitivity, so they prefer to stay still rather than moving about or uh, say pacing up and down the room as such, as you may see with other types of headaches. A typical thing that people who have migraines actually do is just go to sleep and sit in a very dark, quiet room, because they may also have photophobia or phonophobia. Some patients also have nausea and vomiting, and sometimes the vomiting helps to relieve the migraine. These patients will have a normal, these patients should have a normal examination. So if you have someone you suspect has a migraine and you do a cranial nerve examination, and they have signs which indicate, say, focal neurology, this would be quite atypical and should indicate further investigation. And so this image just helps to reiterate what I've said. So sonophobia, photophobia, the patients may have a very quiet voice because speaking makes the pain worse. Unilateral, so they may be complaining of pain on one side of the head. And then, yes, and vomiting may be something which occurs during the migraine headache. So with the investigation of migraine, this is quite consistent with other types of headaches. You want to do a cranial nerve examination, peripheral nerve examination. You want to take a history with regards to the headache. You want to know what happened before, during, and after the headache. What triggered it? How did you feel before the headache? Have you had a history of headaches in the past? A family history? What medication are you on? History of head injury. During the headache, how did you feel? How was your vision? Were you able to move around? Did you notice any abnormal sensations? And afterwards, did you recover very quickly? Was there any sort of residual weakness? Things along these lines. So the chronology before, during, and after for headaches with regards to history taking. Then with bloods, Essentially, you're doing further investigations in order to rule out differentials. Um, and also in order to determine a baseline, as once you start certain medication, it's important to know what the patient's physiological status was beforehand, and then certain investigations are done in particular age groups. So in a person who's say over the age of 50 or 60 that presents with a migraine, you would want to do ESR in order to rule out, say, giant cell arteritis. The MELAS questionnaire is essentially a list of questions which can be used to help contribute to the diagnosis of a migraine. Lumbar puncture and CSF culture. In some people, it's hard to determine whether or not they have, say, a migraine or meningitis. It's usually sensible to do a CT or MRI beforehand, as space-occupying lesions can also present in somewhat similar ways, and doing a lumbar puncture on a person with a space-occupying lesion is a bad idea, as it can lead to tonsillar herniation. CT and MRI, again, to rule out, say, space-occupying lesions, or subarachnoid hemorrhages or ischemic lesions, which may present in similar ways. So the management of migraines. So there's conservative management, the acute management, and preventative management. So the conservative management is those things such as avoiding triggers, regularity of meals and sleeping pattern to avoid, again, essentially avoiding triggers which may cause the migraine, and rebreathing into a paper bag, which has been shown to help relieve the pain associated with migraines. So with regards to the acute treatment, so there's a combination therapy and monotherapy for the relief of the pain, and then antiemetics to help with the nausea and vomiting associated with migraines. So the combination therapy consists of an oral triptan with an NSAID, or an oral triptan with paracetamol. The triptans, so sumatriptan or zolmitriptan, can be given orally or nasally. Say for example, an NSAID you may prescribe would be something such as ibuprofen, say 400 to 600 milligrams at one for just one dose, and then the paracetamol could be say 1 gram for one dose. And then again, say the monotherapy may be just ibuprofen or just paracetamol. And the reason why you may give monotherapy is that in some patients who have, say, ischemic heart disease or coronary spasm, hypertension, or have recently used lithium SSRIs or ergot use is contraindicated. In this group of patients with vascular risk factors, it's because it increases the risk of myocardial infarction, whereas in patients who have recently taken, say, SSRIs or ergot use, there is an increased risk of serotonin syndrome. Because the triptans are 5-HT1 receptor agonists and can cause essentially serotonin syndrome. And then the antiemetics, D2 antagonists, such as domperidone, metoclopramide, or H1 antagonist, cyclizine. You would usually try to avoid giving D2 antagonists, such as domperidone and metoclopramide, to young women, as there is a particular risk of acute dystonia. So in this case, you may give cyclizine 50 milligrams instead. So a bit about the pharmacology of triptans. So as I've mentioned, the 5-HT1 receptor agonists. So they bind to the 5-HT1 serotonin receptor. Triptans are not indicated in hemiplegic bacillar or retinal migraines. And usually if you start a patient on a triptan and they don't respond, you may consider a different one. And then sumatriptan and zolmitriptan have actually been licensed in children. So as I mentioned with regards to the pathophysiology, you have a trigger, some sort of trigger. This may be the aura, which is the spreading cortical depression, which then leads to the release of vasoactive neuropeptides and the activation of trigeminal vascular afferents. This then leads to the sensitization of pain. Furthermore, parasympathetics may sustain vasodilation and promote associated symptoms. So this combination of a trigger leading to the release of vasoactive neuropeptides, sensitization of the trigeminal nerve and trigeminal ganglion, along with vasodilation, leads to the migraine. By giving triptans, this stimulates the 5-HT1 receptor causing vasoconstriction, helping to really reduce the pathophysiological cause of the migraine. There's also preventative treatment for migraines. This is given with the aim to reduce the frequency of migraines, the severity, and the duration. So you would use these factors in order to determine whether or not your patient is responding to treatment. The preventative management is indicated if they have at least 2 attacks per month, if there's an increase in frequency of the headaches, and if they have significant disability because of the headaches, or if they cannot take suitable treatment for the acute attacks. So different drugs which may be given include topiramate, propranolol, and amitriptyline. So topiramate, you would usually start off with a low dose of about 25 milligrams per day, and slowly titrate this up to 100 milligrams twice per day. The patients may need to be on this for about 2 to 3 months to see a response. However, it's important to consider the side effects. It's teratogenic, so you wouldn't want to give this to a woman of reproductive age, or if you were to give it to her, she would need to be on some sort of contraceptive. It can also cause concentration and memory problems, fatigue, and anorexia, so loss of appetite. Furthermore, it can cause metabolic acidosis and increase the risk of kidney stones and acute angle closure glaucoma. Propranolol, so this can take about 12 weeks for a therapeutic effect to become apparent. It has a similar efficacy compared to topiramate and can be used in children. However, in people who have asthma, it's contraindicated. And furthermore, propranolol, similar to other beta blockers, can cause symptoms such as depression, postural hypertension, impotency, and so on. Amitriptyline may be more effective than propranolol in some situations, and it tends to have a faster response than propranolol, and it's typically a low dose amitriptyline, 25 to 75 milligrams at night. So moving on to tension headaches. So tension headaches would be the most common headache that people would have, not the most common episodic headache. So it's very common for people to have at least one tension headache at one point in their life, but it doesn't tend to be episodic. They're more common in women than men, and with regards to the etiology, it's thought to be related to the contraction of the pericranial muscles following psychological stress or disturbed sleep pattern. And so as a result, there is a very wide range of etiologies or causes. So say you could find tension headaches in a 15-year-old child who's having difficulties with their examinations, or an 80-year-old person who's worried about the loss of function, and then the worry that they may have to go to a nursing home, a care home, for example. So there's no specific etiology. However, the general theme associated with the etiology of tension headaches is that it's psychological stress or disturbed sleep pattern leading to persistent pericranial muscle contraction, and then pain, as that's one of the structures around the skull, which is sensitive and may lead to the symptoms of headaches. So with regards to the actual clinical features of tension headaches tend to be of a sort of frontal-occipital band-like pain, so on both sides. So the patient may say that it feels as if there's a band wrapped around their head, squeezing the head, causing a lot of pain. As I mentioned, it tends to be associated with stress, so if they experience something stressful, it may cause an exacerbation of the tension headache. Again, as I've said, a band-like tightness would be the character of the pain. It may radiate forwards and is sometimes associated with tenderness of the scalp. It's further associated with things such as anxiety, depression, again, as I've mentioned, stress. However, the patient should not have, say, nausea or vomiting, or photophobia, or phonophobia, or osmophobia, which would indicate other causes of headache. It typically or classically lasts 30 minutes to 7 days, and tends to be relieved by activity. So, as I've mentioned, it occurs due to muscle spasm and overcontraction of the pericranial muscles secondary to stress, as these diagrams can show. Furthermore, these diagrams also describe things such as sleep disturbance, which can lead to a diurnal variant of the headaches, psychogenic factors. So in this image, you can see a person whose boss is being quite mean to her. So one of the presentations may be that this person has headaches when they go to work, and this is because of their mean boss. In this image, there's a man being scolded by his wife. Again, it may be that this person has a headache when they leave their job because of the home environment. So it's important to have a broad mind with regards to the etiology of tension headaches. Now with the classification, so as I've mentioned, it classically lasts between 30 minutes to 7 days, and usually has at least two of a bilateral location, so on both sides, pressing, tightening in nature, so a band-like headache. It's mild / moderate in intensity, so it's not as bad as, say, a migraine, and it's not aggravated by physical activity. And it's important to note that there is no nausea or vomiting or photophobia, and it's not better accounted by any other cause. And then it can be further classified into infrequent, frequent, or chronic. Infrequent is when a person has 10 episodes occurring at less than a month. So this could be a person who has 10 episodes spread over an entire year without more than one in a month. Frequent is when a person has 10 episodes occurring between 1 to 14 times a month. So, for example, if a person has 10 episodes over a period of 8 months, and then or 5 months, and then they have 2 every month, this would be frequent. And then chronic would be when it occurs on more than 15 or more days per month for more than 3 months. So the investigations, again, are consistent with migraines. You want to ask these sort of questions. You want to do a cranial nerve exam, peripheral nervous system exam, before, during, after, with regards to the history, and then the past medical history, and so on. You want to do bloods to rule out differentials, mid-ask questionnaire, as some people may actually have migraines, will give you incorrect information with regards to their history. And then with regards to tension headaches, a lumbar puncture or CT or MRI would be quite excessive, but if you're unsure or you suspect that there are red flag features or things which are quite worrying, then you may consider doing a lumbar puncture or CT or MRI. And so the red flag features would be things such as weight loss, if they have cranial nerve palsies or focal neurology, if they have a history of malignancy, if there are signs which indicate raised intracranial pressure headaches, and then if you suspect that it may be due to a malignancy, you would want to do a CT or MRI. And so the management of tension headaches, describing tension headaches and understanding the etiology is quite straightforward. However, in practice, the actual treatment can be quite difficult. Some patients may benefit from just counseling and cognitive behavioral therapy. And again, as I've mentioned with regards to the etiology, because it's so broad, say a person who has tension headaches because of examinations may benefit from, say, just simple analgesia for a week until the examinations are gone, so that they can study, etc. Whereas a person who's persistently worried because of their job or because of their living quality of life or because of the future, say an elderly person who's worried about being taken to a care home, giving them analgesia, especially opioids, would be counterproductive and could lead to a dependence on the analgesia and the further development of medication overuse headaches. And these people, counseling and cognitive behavioral therapy would be much more useful. However, the NICE guidelines, the NICE CQS, say that if a person has an episodic headache, then you could use, say, simple analgesia, paracetamol, and NSAIDs. If it's chronic, then things such as low-dose amitriptyline or 10 sessions of acupuncture over a period of 5 to 8 weeks would be useful. So moving on to trigeminal autonomic cephalgias. So this includes cluster headaches, chronic paroxysmal hemicrania, and something called short-lasting unilateral neuralgia-form headaches with conjunctival injection and tearing. And so of these, the most common type would be cluster headaches. And this is a table which just goes over the how it presents, the severity of the pain, how long they last, and the treatment and so on, which can be useful for your revision. So cluster headaches. They're called cluster headaches because they occur in clusters. Uh, they tend to be more common in men than women, so a ratio of about 15 to 1. Somewhat rare, so 0.1% of the population. There tends to be a very strong family history. First-degree family members are about 18 times more likely, and they typically present between the ages of 20 to 40, and about 70% is before 30 years of age. There are particular risk factors such as a history of head trauma, heavy smoking, or alcohol intake. And so the pathophysiology isn't well understood. It's thought that a combination of genetic predispositions or triggers such as alcohol, smoking, or head trauma initiate the headache. Something known as the trigeminal parasympathetic reflex causes potentiation of the trigeminal pain, so pain over the trigeminal regions. And then this leads to the interpretation of innocuous or innocent stimuli being noxious or damaging stimuli. And so nociceptive information from the pain-sensitive structures in the face, which is then sent to the hypothalamus. And so this diagram then helps to understand how a predisposition through genetics and the combination of triggers then leads to a stimulation of the hypothalamus, and then a circadian repetitive pattern of pain, which is combined with trigeminal pain, so pain over the trigeminal region, and dysfunction of the autonomic nervous system. And so with regards to the clinical features of cluster headaches, so they're unilateral, retroorbital, so behind the eye, and the temporal region or the maxillary region. They tend to occur suddenly, and the patient will have the headaches at the same time for weeks at a time. So they may say that they have the headache every time at 8 in the evening, and this lasted, say, 3 weeks, and then they won't have it again for another year, and then next year, in, say, February, they'll have another cluster of these headaches at 8 o'clock for 3 weeks, and then it doesn't come again, and then the next year again in February, the same thing, so 3 weeks of headaches starting at 8 o'clock. And this is why they're called cluster headaches, because they occur in clusters. I just want to emphasize that. The pain is usually described as a boring, sharp, piercing, or burning or pulsating pain. It's associated with suicidal thoughts. This is because the pain of cluster headaches is thought to be one of the worst imaginable pains, and the patients may consider suicide in order to escape the pain. There are also autonomic features such as conjunctival injection or lacrimation, which is seen in about 90% of patients. Nasal congestion or rhinorrhea. So in this image you can see a man with a runny nose, he's tearing, eyelid edema, swollen eye, associated with ptosis and erythema of the face. The patients may also vomit or have photophobia or phonophobia as well, along with meiosis and ptosis, as I mentioned. Characteristically lasts between 15 to 180 minutes, and the patient may prefer to move around, and so they may walk up and down the room, they may writhe about in their beds, and some patients have been known to actually bang their head against the wall in order to distract them from the debilitating pain of a cluster headache. And as I mentioned, it may be the worst pain they've ever experienced. And so, as I've described, it's typically nocturnal. It occurs in clusters, so at certain periods of the day, and lasting a certain amount of time. There are other triggers of cluster headaches, and so this includes things such as watching TV, alcohol, hot weather, stress, the use of things such as nitroglycerin, and so on. So the classification of cluster headaches. At least 5 attacks lasting 15 to 180 minutes, with at least one of ipsilateral conjunctival injection or lacrimation, associated with nasal congestion or rhinorrhea, eyelid edema, forehead or facial sweating, a sensation of fullness in the ear, and meiosis or ptosis. They occur between 1 every other day or 8 per day. Episodic cluster headaches last for periods of about 7 days to 1 year, with pain-free periods for 1 month, and the cluster periods last about 2 weeks to 3 months, whereas chronic cluster headaches occur for more than 1 year, with a remission for less than 1 month. And so the investigation of cluster headaches, again, is consistent with other types of headaches. So you want to take a history, you want to know what happened before, during, and after, do a cranial nerve exam, upper and lower limb peripheral nervous system exam, bloods to rule out differentials, questionnaires to rule out differentials again. In patients with cluster headaches, you may be more inclined to do a CT or MRI in order to rule out, say, a space-occupying lesion, which may present in a somewhat similar way. Following this, you may consider a lumbar puncture in an acute setting. And so the management of cluster headaches, as I mentioned, you should consider neuroimaging if it's the first bout of cluster headaches. The acute management consists of oxygen, 100% oxygen, at 12 to 15 liters per minute with a non-rebreather mask. Furthermore, subcutaneous or nasal administration of sumatriptan at a maximum of about 12 milligrams per day, along with intranasal lidocaine, have been shown to help relieve the pain associated with cluster headaches. With regards to the prophylactic management, if it's chronic, drugs such as verapamil and lithium antipyramate have been shown to relieve the pain, whereas if it's episodic, prednisolone and verapamil are indicated. And you should also discuss avoidance of triggers such as alcohol and smoking. So, as I've mentioned, chronic paroxysmal hemicrania, otherwise known as Sjaastad syndrome, is more common in females than males, and tends to be associated with things such as arterial aneurysms or cerebral artery infarctions or brain tumors. The clinical presentation is a headache which lasts at least 20 attacks, which last between 2 to 30 minutes long, occurring more than 5 times per day, affecting the entire head, which can be provoked by head movement and is not associated with nausea or vomiting, and the definitive management would be indomethacin. So short-lasting unilateral neuralgiform headaches, or SUNCT, compared to other forms of the primary headaches, this is very, very rare, not as common. However, it tends to present with an excruciating burning stabbing or electrical pain. It can last between 5 seconds to 5 minutes and occur up to 200 times per day. It tends to be associated with things such as lacrimation, ptosis, eyelid edema, or nasal blockage, and can be triggered by simple stimuli. The treatment would be drugs such as pregabalin, gabapentin, and topiramate. And so this is a table just going over the different types of primary headache and can be useful for your revision. So moving on to secondary headaches. There's raised intracranial pressure headaches, low intracranial pressure, trigeminal neuralgia, vascular conditions, and referred pain. So I'm going to go over raised and low intracranial pressure headaches along with trigeminal neuralgia. However, vascular conditions such as intracranial hemorrhage or subdural hemorrhage, venous malformation, and giant cell arteritis are in the other lectures, so I'm not going to go over those topics. And it's important to understand that people may have headaches as a result of referred pain due to sensitization of other local structures such as the teeth, the ears, the eyes, and so on. So, causes of raised intracranial pressure. This includes idiopathic intracranial hypertension, which I'm going to go into more detail, hydrocephalus, secondary to a wide range of things such as a tumor or outflow obstruction or meningitis or infections, which can also cause hydrocephalus, or syringomyelia, which can also cause hydrocephalus. Space-occupying lesions such as, again, malignancies or tumors. As I've mentioned, meningitis or encephalitis can cause raised intracranial pressure, and so can trauma due to bleeding inside the skull, inside the fixed box, or due to the development of hydrocephalus following the trauma. The typical presentation of a raised intracranial pressure headache, the patient may complain of pain which is worse in the morning, whilst coughing or straining or doing the Valsalva maneuver. It's associated with nausea and vomiting and visual disturbance. On examination, you may see papilledema, or things indicating focal signs of the actual lesion or the position of the lesion, or false localizing signs. So, say if a person has a personality change and a change in the executive function, this would indicate that it's a frontal lobe tumor. However, if it's then associated with a sixth nerve palsy, and you do a CT and again, the tumor is in the frontal lobe, this would then be a false localizing sign, which occurs due to compression of the abducens nerve secondary to the raised intracranial pressure rather than the actual tumor, the physical position of the tumor itself. In these patients, you want to do a CT or MRI before you even get close to a lumbar puncture needle, as there is a significant risk of coning and herniation of the cerebellar tonsils. So, idiopathic intracranial hypertension, this is one of the causes of raised intracranial pressure headaches. Typically presents in overweight women of childbearing age. It's also known as pseudotumor cerebri. So they're typically between the ages of 20 to 44. It's somewhat rare with an incidence of 90 to 100 per 100,000. And there's a definite positive relationship between benign intracranial hypertension and obesity. So idiopathic intracranial hypertension is thought to be related to vascular, hormonal, and cellular pathologies. So stenosis of the transverse sinus is associated with intracranial hypertension. However, it's thought that this isn't the cause and is rather secondary to the raised intracranial pressure. Excess of aldosterone affects the mineralocorticoid receptor of the choroid plexus, leading to raised CSF production, and it's thought that this is related to the obesity and the hormonal abnormalities associated with obesity. Furthermore, it has been shown that an idiopathic intracranial hypertension is associated with increased outflow resistance of the CSF, and it's thought that this is an effect of estrogen on the epithelial cells of the CSF. So, moving on to the clinical presentation. So, the patients with idiopathic intracranial hypertension will present with headaches. And this can be in any location of the brain. Typically occurs every day, and is worse in the morning and when they do the Valsalva maneuver, similar to other causes of raised intracranial pressure. It may also be associated with nausea, vomiting, and photophobia. Pulsatil tinnitus is typically a whooshing sound, and this may be unilateral or bilateral and occurs due to the transmission of vascular pulses by the CSF under high pressure. The patients may also present with ophthalmic signs. So ophthalmic signs such as transient vision loss. So this can last a few seconds at a time and occurs due to edema of the optic disc. Diplopia occurs due to a palsy of the sixth nerve. Photopsia, so flashings of light, again related to optic disc edema. In some patients there may be long-term vision loss. And loss of visual fields if the disease is not treated. And papilledema may be seen on an examination, and this indicates the raised intracranial pressure. So the investigations of idiopathic intracranial hypertension. So similar to the other causes of headache, you want to do an examination and history and bloods. However, in these patients, because these signs are somewhat similar to a tumor, you would be much more vigilant. You would want to do neuroimaging to rule out any malignancies or space-occupying lesions. Following this, if you don't find a space-occupying lesion, you would consider a lumbar puncture with further ophthalmic assessment. So neuroimaging in idiopathic intracranial hypertension. This could be a MRI with venography or CT scan, and this is done to rule out secondary causes of intracranial hypertension. Furthermore, when you do this investigation, you'll see normal brain parenchyma. However, in some patients, there may be a prominence of the subarachnoid space around the optic nerve, further associated with stenosis of the venous sinus. And so this diagram is showing distal transverse sinus stenosis, and this also shows stenosis of the distal transverse sinus. And it's thought that this occurs secondary to the raised intracranial pressure. So lumbar puncture, as I've mentioned many times, you should do neuroimaging before considering a lumbar puncture due to the risk of uncalled or tonsillar herniation. In patients with idiopathic intracranial hypertension, the opening pressures would be more than 25 centimeters of water in adults or 28 in children. You may also do a CSF analysis. This should be negative. However, you'd want to send it off for cell count, glucose, protein, gram staining culture in order to rule out meningitis. The ophthalmic evaluation consists of ophthalmoscopy, visual acuity, and perimetry. This is both done to diagnose and to monitor the progression of the disease, as ophthalmoscopy showing papilledema can be, along with the clinical signs, symptoms and signs, would be diagnostic for idiopathic intracranial hypertension. However, if this is not if you're attempting to treat it and there is a poor response and you see worsening of the papilledema, this indicates that the patient may have a deterioration of the vision. Furthermore, visual field testing can help you to track the deterioration of the patient's vision with the progression of the disease. Furthermore, with visual acuity. And so there's something known as the modified Dandy criteria. This is used in the diagnosis of idiopathic intracranial hypertension, and it consists of the symptoms and signs of a raised intracranial pressure headache, the absence of localizing findings on neurologic examination, the absence of deformity, displacement or obstruction of the ventricular system with normal neurodiagnostic studies. The patient has to be alert and awake, and there is no other cause of the raised intracranial pressure. And so the management of idiopathic intracranial hypertension consists of things such as diagnostic lumbar puncture, weight loss, carbonic anhydrase inhibitors, topiramate, and optic nerve sheath defenestration. And so the lumbar puncture can help to relieve symptoms, and in some patients actually leads to complete resolution due to a persistent leak, so a persistent reduction in the intracranial pressure. Weight loss of about 5 to 10% has also been shown to be very useful in patients. And as I've mentioned, as obesity and hyperestrogenism and hormonal abnormalities associated with the pathophysiology, it's thought that this is the means by which weight loss helps to treat idiopathic intracranial hypertension. Carbonic anhydrase inhibitors such as acetazolamide can help to reduce the production of cerebrospinal fluid, helping to treat idiopathic intracranial hypertension. Furthermore, topiramate has been shown to have weak carbonic anhydrase activity and can help to contribute to weight loss. So optic nerve sheath defenestration. So this essentially consists of making slits in the dura mater and the arachnoid posterior to the globe of the eye, which helps to increase the outflow of CSF, reducing pressure on the optic nerve and reducing papilledema. So low intracranial pressure headaches. This can be spontaneous. This can be following lumbar punctures. It can be following trauma or following surgery, so some sort of CNS surgery, for example. And it's thought that these causes or these triggers lead to a continuous leakage of CSF and intracranial hypotension. And intracranial hypotension would lead to a sagging of the brain and traction on the dural and vascular elements, as one of the functions of the CSF is to sort of help to provide buoyancy to the brain and to help it float. And so traction and a loss of this buoyancy will lead to tension on the dural and vascular elements in the brain, which are the pain-sensitive elements leading to the pain associated with low intracranial pressure headaches. And so the typical presentation is pain which is worse when the patient is upright, so standing up. And this is because it leads to both traction on the sensitive elements and increased flow downwards. It can be triggered by coughing or sneezing, as this leads to traction on these sensitive elements. Things such as bending over and exercise, again for the same reason, can lead to exacerbation of the pain. And compression of the jugular vein may exacerbate the pain. It tends to be associated with nausea and vomiting as well. And so patients with low intracranial pressure headaches, the investigations you'd want to do is, again, similar to the other headaches, you'd want to do history examination and bloods. However, with regards to neuroimaging, it's quite important to do gadolinium enhancement, as this can help to identify thickening of the dura secondary to the low intracranial pressure, which tends to be associated with intracranial hypertension, as shown in these diagrams. So you can see that there is thickening of the dura, so abnormally thick dura. And in this image, there's something known as the flat tire sign, which occurs due to descent of the cerebellar tonsils. You may also consider doing a lumbar puncture, and this would show that the patient has a low CSF pressure. However, it's important to note that the lumbar puncture can cause worsening of the pain, as that's one of the potential mechanisms of the low intracranial pressure headaches. And so, with regards to the management, if it's immediately after a lumbar puncture, it's been shown that bed rest and being well hydrated can help to relieve the pain. Furthermore, caffeine following low intracranial pressure headaches has been shown to help relieve the pain. In patients who have chronic or long-standing low intracranial pressure headaches, an epidural blood patch in which blood is injected in order to seal a leak can help to, essentially by causing fibrosis with the blood, it can help to patch a potential leak in the dura mater, reducing the leakage of CSF. So moving on to trigeminal neuralgia, otherwise known as tic douloureux. It affects about 100,000 people per year, more common in women, and is typically in people over the age of 50. So trigeminal neuralgia in a young patient should be seen as somewhat suspicious, in particular for multiple sclerosis. So the classical cause of trigeminal neuralgia is vascular compression. So in about 80 to 90% of patients, compression of the trigeminal nerve, typically the superior cerebellar artery, leads to trigeminal neuralgia. However, there are other things which can cause trigeminal neuralgia, such as meningioma, acoustic neuromas, or epidermoid cysts. Secondary, and so these would be the secondary causes of trigeminal neuralgia. So the clinical presentation, there are particular things which may trigger the pain, such as touching of trigger zones, or brushing teeth, shaving, chewing, talking, or cold air, typically on the cheeks. The type 1 presentation would be when they have paroxysmal pain, whereas type 2 is when they have paroxysmal pain, which is associated with a constant background pain. So typically the patients with trigeminal neuralgia will have grimacing or facial muscle spasm, and this is because of the paroxysmal pain. So the patient experiences this very somewhat severe pain, and then they have facial muscle spasming in response. The pain is usually of electric shocks in nature, typically unilateral, and may last a few seconds. If V1 is affected, the trigeminal neuralgia may also be associated with lacrimation, rhinorrhea, or conjunctival injection. And so the diagnostic criteria of trigeminal neuralgia. Patients with trigeminal neuralgia may present with recurrent paroxysms of facial pain in the distribution of the trigeminal nerve, which may last a few seconds to 2 minutes. It tends to be of a severe intensity, and as I've mentioned, it's electric shock-like or shooting, and may be precipitated by innocuous stimuli such as chewing or brushing your teeth, and there has to be no other alternative diagnosis. for the cause of pain. The investigation, so it's primarily a clinical diagnosis. So you want to do a history examination, blood tests in order to rule out differentials. However, in patients who may present with an atypical presentation, or when you suspect a tumor, you would want to do neuroimaging. Furthermore, an MRI can help to diagnose a multiple sclerosis or a vascular compression of the trigeminal nerve. And so the management of trigeminal neuralgia. So the pharmacologic management consists of carbamazepine. So this may be carbamazepine 100 milligrams twice per day, which is titrated in steps of about 100 to 200 milligrams every 2 weeks until the pain is relieved. In some patients, 200 milligrams three times per day or 4 times per day is sufficient in order to control the paroxysms of pain. However, in some patients, if carbamazepine is not sufficient, you would want to refer to a specialist in order to further investigate and consider alternative medications. And it's also important to know the potential side effects of carbamazepine includes things such as drowsiness, dizziness, double vision, and nausea. And in East Asians, you would want to either avoid giving carbamazepine or test for HLA-B1502 due to the increased risk of Stevens-Johnson syndrome. With regards to the surgical treatment of trigeminal neuralgia, you can do microvascular decompression, and so this essentially consists of doing a craniotomy in order to identify the vessel which is compressing the trigeminal nerve, moving it out of the way, and putting a soft cushion pad in between in order to allow the nerve to recover and to reduce pressure on the nerve. There are also ablative procedures. This consists of things such as a thermocoagulation or injection of or a chemical injection into the artery in order to cause blockage of the artery, reduce the compression of the artery on the trigeminal nerve, and then peripheral neuronectomy in cases such as acoustic neuroma, in which you have a vestibular schwannoma causing compression of the trigeminal nerve.